Hello, thank you for joining today's Children's Safety Network webinar. We will begin promptly at 3 p.m. Eastern Time, so just hang with us and we'll get started soon. Hello to everyone who is joining the Children's Safety Network webinar. We will get started in approximately 8 minutes. We will start promptly at 3 p.m. Eastern Time, so just hang with us and we'll be back soon. Hello, and thank you for joining the Children's Safety Network webinar today. The webinar will start promptly in 6 minutes, so just hang tight until we get started. Thank you. Hello, and thank you for joining the Children's Safety Network webinar this afternoon or this morning, depending on where you're located in the country. The webinar will start in 5 minutes, promptly at 3 p.m. Eastern Time, so just hang tight until we can get started. Thank you. Hello, and welcome to the Children's Safety Network webinar. The webinar will start in 3 minutes, so please just hang tight until we can get started. Thank you. Hello, and welcome to the Children's Safety Network webinar. We will begin the webinar in 2 minutes. Hello, everyone, and welcome to the Children's Safety Network webinar. The webinar topic for today is synthetic marijuana. What is it? Why is it dangerous? And how can we prevent youth from using it? I'm Shelley Stevens Stidham, and I'm going to be the moderator for today. I am the Director of Community Health Impact at Parkland Health and Hospital System in Dallas, Texas, and I'm also an active member of the Children's Safety Now Alliance. So just as a reminder, the Children's Safety Network is supported by a grant from the Health Resources and Services Administration, or HRSA, of which we're extremely grateful. They make the funding available so that we can provide resources such as this webinar to the many people across the country. So we want to thank HRSA for that. Before I introduce our two speakers today, my colleague Rebecca Wilmer has a few technical announcements. Rebecca?
Thanks, Shelley. So audio is being broadcast through your computer speakers, and the quality of the audio depends on the speed of your internet connection. So if the audio is choppy, please find a more stable internet connection, or you can listen over the phone by dialing 866-835-7973. If you are listening through the phone line, please mute your computer speakers to eliminate any echoes. Phone lines will be muted during the presentation so that we can eliminate any background noise. Answers to frequently asked questions are in the webinar instructions pod that you can find in the upper left-hand corner. And if you have questions or technical issues, you can type them into the Q&A box on the bottom left at any time. After the presentation, we will pause for the presenters to answer any of your questions. We have a PDF of the slides available to download above the slide deck. Click on PDF of the slides and then select the Download Files button to save the document to your computer. And this webinar will be recorded and the archive will be sent out to all registrants within 2 weeks. All right, back to you, Shelley.
Thank you, Rebecca. And just as a reminder, we have two very esteemed speakers today. They will speak for about 20 minutes or so, and we are going to hold questions until the end. So our first speaker today is Dr. Seth Ammerman. Dr. Ammerman is a clinical professor in pediatrics and adolescent medicine at Stanford University. He is the founder and the medical director of the Teen Health Van, a mobile clinic program providing comprehensive primary health care services to homeless, uninsured, and underinsured youth. Dr. Ammerman's research interests include substance use in adolescents, underserved or at-risk youth, eating disorders, and use of mobile technology for improving adolescent health. He is a fellow of the American Academy of Pediatrics and chair of the Northern California chapter of the American Academy of Pediatrics Substance Abuse Committee. Our second speaker will be Krista Osterthaler. She is the Vice President for the National Data Services at the American Association of Poison Control Centers, where she oversees the National Poison Data System. The National Poison Data System is the data warehouse for the nation's 55 poison control centers, which provide free, private, expert information and treatment advice 24 hours a day, 7 days a week, 365 days a year through the National Poison Helpline. Krista began her career as a high school science and math teacher before earning her master's degree in public health, and later an additional graduate certificate in epidemiology from George Washington University. Krista joined Poison Control as a poison prevention educator with the National Capital Poison Center in 2011 before taking over the Outreach, Public Education, and Communications Department. During her time, Krista has served as the chair of the National Poison Prevention Council. She's developed multiple poison prevention education programs and served on several relevant task forces. So without further ado, I'm going to turn it over to Dr. Ammerman.
Good afternoon. Welcome to everyone, and it's a pleasure to be involved with this webinar on synthetic cannabinoids in marijuana. /marijuana. I have no disclosures. And why this talk? There are a number of reasons, but three listed include that synthetic marijuana or cannabinoids use is becoming more common among adolescents. Synthetic cannabinoids are often marketed as a safe, legal alternative to marijuana. And they're also marketed as not showing up in routine drug screening, so it's easier to hide use, which can be appealing to some users. I have a number of objectives for my part of the talk, which is I will discuss SBIRT, which stands for Screening, Brief Intervention, and Referral for Treatment. I'll discuss my approach to patients who do use synthetic marijuana as part of general screening for substance use. I will also review the current literature on synthetic marijuana, and I will discuss available prevention efforts. I'll start with patient experiences. These are what patients have told me about their use of synthetic marijuana or cannabinoids. They like it. They enjoy the high. To them, it's similar to marijuana. However, I've had many patients who've had bad experiences, unfortunately, and that includes having tachycardia or rapid heart rate, vomiting, engaging in violent behavior, suicidal thinking, and even the development of seizures. And I've also had patients who have ended up in the hospital with hypertension, acute hypertension, with reduced blood supply to the heart, kidney damage, and even death. So the side effects, the adverse consequences of using synthetic cannabinoids can be highly dangerous and even deadly. There are three major longitudinal data sets in the United States that look at drug use epidemiology in youth. One is the Youth Risk Behavior Survey, which is sponsored by the Centers for Disease Control and Prevention. The second is Monitoring the Future, which is sponsored by the University of Michigan and the National Institute of Drug Abuse. And the third is the National Survey of Drug Use and Health, or the National Household Survey on Drug Abuse. It used to be called by the Substance Abuse and Mental Health Services Administration of the Feds. All of these longitudinal data sets are great sources for looking at drug use over time, and they all use somewhat different methodology, which is also useful and important. In general, their findings are similar, although again, with different methodology, sometimes the findings may be somewhat, they'll overlap but not be identical. I'm going to discuss a couple. I'm going to start with Monitoring the Future. The latest data from Monitoring the Future is 2014 to 15 on synthetic cannabinoid use, and I'm just going to talk about 12th graders. Monitoring the Future actually is a nationally represented junior high or middle school and high school sample of 8th, 10th, and 12th graders for all different drugs, ranging from alcohol, tobacco, marijuana, and so on. But just here, in terms of 12th graders, current use of synthetic cannabinoids, and current use is defined as having used at least once in the past 30 days, is 2.9%. Of those 2.9%, almost 50% were using more than 3 times a month. And interestingly, use of synthetic cannabinoids does seem to go along with other risky behaviors and polysubstance use. So these users were more likely to report more recent and often more frequent use of LSD, cocaine, heroin, and or non-medical use of opioids compared with marijuana-only users. Also compared with current marijuana-only users, the synthetic cannabinoid users were more likely to report lower parent education, current use of a higher number of illegal drugs, and those using heavily, which is defined as 10 or more times a month, were more likely to be boys, frequent marijuana users, African American, and again, users of multiple illegal drugs. Longitudinal predictors of synthetic cannabinoids use in adolescents includes depressive symptoms, use of marijuana, and alcohol use. Interestingly and importantly, synthetic cannabinoid use in and of itself does not predict later use of marijuana. I'll next move to the Youth Risk Behavior Survey from 2015 are the most recent data, and these tend to be state-based. Students who ever use synthetic cannabinoids were more likely than students who ever used marijuana only to have used marijuana, started using marijuana before the age of 13, to have used marijuana more frequently, greater than 1 or more times in the past month, and to have used it greater than 20 or more times in the past month. Additionally, several injury and violence behaviors were more prevalent among students who ever used synthetic cannabinoids compared with those who only used marijuana. Three more common ones were that they rode with a driver who had been drinking alcohol, did not go to school because of safety concerns, and had engaged in a physical fight. So definitely synthetic cannabinoid use is associated with more risky behaviors and unhealthy behaviors. I'm going to move on to a statement from the FDA that came out this past July warning about significant health risks of contaminated illegal synthetic cannabinoid products. Krista will be talking more about this, but this FDA statement talked about how, as I mentioned, that synthetic cannabinoids can have adverse effects, including increase in heart rate, vomiting, violent behavior, suicidal thoughts, and reduced blood supply to organs and causing seizures. However, what has happened more recently is that brodifacoum has now been added to synthetic cannabinoids because it's thought to extend the duration of the drug euphoria or the drug high. The problem with this brodifacoum is that it causes severe bleeding, and there have been a number of reports of hospitalizations and even deaths with brodifacoum contaminated or it's intentionally added to synthetic cannabinoids. And when this occurs, what happens with standard coagulation tests such as prothrombin, that can be dramatically elevated, which means giving high doses of vitamin K and other supportive care can potentially be life-saving. The FDA, though, was also concerned about the potential contamination of donated blood products because they had received reports of donors who had used synthetic cannabinoids contaminated with brodifacoum, and that can cause, again, problems with abnormal bleeding. So both for the blood donor and the donated blood components. So this is an issue, and again, Krista will get into this more in her part of the webinar. I would like you all now to answer this poll. All of the following are true about synthetic cannabinoids except for one of these 5. And I want you to choose the letter of the incorrect response. A, synthetic cannabinoids are a large heterogeneous group of chemicals that are structurally similar to delta-9 tetrahydrocannabinol, which is THC, THC being the psychoactive component of marijuana. In other words, that's what you use to get high. B, most synthetic cannabinoids show up in routine drug tests. C, synthetic cannabinoids are available to adolescents at convenience stores and smoke shops and on the internet. D, popular brands include K2, Spice, Crazy Monkey, and Scooby snacks. And finally, synthetic cannabinoids are often marked or labeled as, quote, not for human consumption, end quote. And as we're looking at the results here, it looks like the vast majority of you have correctly answered, which is that the incorrect answer is that most synthetic cannabinoids show up in routine urine drug testing. One of the, quote, benefits for some users is that most do not show up in routine urine drug testing. This, of course, also can cause problems if someone's using and overdoses or has problems, and Krista will be getting into that as well. To summarize the poll answers, again, synthetic cannabinoids are a large heterogeneous group of chemicals that are similar to THC. They are high efficacy full agonists of our endocannabinoid receptors, CB1 and CB2, in our brain and nervous systems. They are available to adolescents and adults, of course, at convenience stores and smoke shops and on the internet. The popular brands do include K2 Spice, Crazy Monkey, and Scooby snacks. They are typically categorized as designer or party drugs. They are often marked or labeled as not for human consumption. It is very easy for chemists to change the structure of the chemical by adding or subtracting a group here or there, and that helps skirt legal requirements that try to keep pace with all this. And again, they usually do not show up on routine urine drug tests. So thank you for participating in the poll. Now, I'm going to move on to what we as primary care providers and adolescent healthcare providers, how we approach looking at adolescent substance use and then specifically synthetic cannabinoids. There's so many drugs out there, and they have so many names, and we have so little time. We have a lot to do during an office visit. What has come about is expert to help streamline and focus on substance use in the office setting. And expert, as I mentioned, stands for Screening, Brief Intervention, and Referral for Treatment. And it has a three-part opening simple screening question, which if the answer is yes, we then use a tool called the CRAFT, which I will get into. And if the answer is no, then we're virtually done. Now, very typically for adolescents, this is when we screen in the office setting for substance use. Number one is when adolescents come in for preventive services, their annual checkup for anticipatory guidance. Any youth undergoing mental health treatment, because we know that substance use rates are much higher in youth who have mental health issues such as depression or anxiety. For school dropouts, again, much higher rates of substance use. For youth demonstrating behavioral changes, school problems such as grades dropping, missing a lot of school, acute medical problems because some of these drugs can cause GI disturbances, or the patient had trauma while being high and either bicycling or driving. And then just if a parent or we have concerns that the patient is having substance use or issues or problem substance use. So these are the 7 common indications. For adolescents, it's very important to talk about confidentiality because if adolescents are concerned they won't be kept confidential, they may not be honest in their answers about substance use. So we always let them know that unless we're concerned about imminent harm or danger to the patient or others, then we can keep the information confidential. And that's true throughout every state. But if we are concerned about imminent harm or danger, then we can break confidentiality. The expert 3-part opening question is, in the past 12 months, have you, 1, drunk any alcohol, more than a few sips, smoked any marijuana, or used any other drugs to get high, including illegal drugs, non-prescription drugs, prescription drugs, or things you sniff or huff? One thing we have started to add in, which is not part of the typical expert opening question, is that do you use alcohol, marijuana, or other drugs to treat problems such as ADHD, anxiety, depression, pain, or to help with sleep? Because many of us in the field are finding that more kids are using, if you just ask them, are you using these drugs to get high, they'll say no, even though that may have how they initially used them. But then they realize, oh, it helped my pain, it helped my sleep, it helped my depression, it helped my anxiety from their point of view. And so adding in this part of the question, too, gives us more positives than otherwise we would have and opens for more discussion with the patient about substance use. If they answer no to that opening screening question, I'll back up here, then we say to the patient, great, you're acting healthy, you're making smart choices, please keep it up. So we don't ignore the fact they're not using, but we comment on the fact that they're doing good and continue that. But if they answer yes, then we use the CRAFT. And it's a reliable and valid screening tool for adolescent substance use. It's similar to the adult CAGE, which you all may have heard of, which is just for alcohol. But the CRAFT is for alcohol and other drugs. And there's 6 elements. Each yes gets a score of 1, and 2 or more of positives, so a score of 2 of 6 or more, means that the likely problem drug use, the higher the score, the more likely the severity. And we always do what's called a brief intervention, meaning if an adolescent is using substances, we really need to comment on them, figure out their motivations, and try to encourage them to cut back or quit. So these are the elements of the CRAFT. The C stands for, have you ever ridden in a car driven by someone, including yourself, who is high or had been using alcohol or drugs? And even if the answer is no, we always encourage them never, of course, to do so. And if they have, of course, tell them that not a good idea. R stands for relax. Do you ever use alcohol or drugs to relax or feel better about yourself? Now, one thing I want to point out is that adults do this commonly. For example, they'll drink alcohol, and I'll talk about moderate use to relax. And in general, we think this is okay for adults, but for adolescents, we don't believe this is a good idea, that you should use alcohol or drugs as a way to relax. The first the A is for alone. Do you use alone? Now, again, adults may use alone because they might be single or widowed or divorced or whatever. But if a kid is using drugs alone, that's very likely to lead to problem use. The first F stands for, do you ever forget things that you did while using alcohol or drugs? And we talk about risky situations, that maybe you would have unprotected sex, or have you done anything stupid, or do you know anyone who's done anything stupid under the influence of alcohol and drugs? And virtually every adolescent does know someone who has done something stupid, and that opens again the discussion about the risks of using these substances. The second F stands for family or friends. Do they ever tell you should cut down on your drinking or drug use? If your family or friends tell you that, then you probably have problem use, and we consider that a red flag. And also the final element, T, have you ever gotten into trouble? If you've gotten into trouble while using alcohol or drugs, that's also a red flag that you probably have some problem use with it. And the main motivational interview and counseling tips we use, talk about the brain development. Most of my adolescent patients don't know that their brain is developing, and when I tell them that, they find it very interesting that it is, and not only that it continues to develop into the 20s, and importantly, regular substance use may alter normal brain development, which is likely not good. Virtually all my patients, all of us, know someone who's an alcoholic or a drug addict, and to point out that Uncle Joe, he didn't start drinking to become an alcoholic, but that the alcohol or drug can take over before you even know it, and you've got to be very conscious and mindful about that. All adolescents I come across don't want anybody or anything controlling them, and so if they're using, I'll say, who controls you, you or the drug? And they almost always tell me, of course, I'm in control. So I say, great, that means you could cut back or quit, right? So let's do just a brief test. You know, see if you can cut back or quit for a weekend or maybe a week, and we strategize about it and see how it goes, and I'll see them back. And then very typically they were unable to cut back or quit. And then that brings up the discussion, well, maybe the drug is controlling you more than you think. And what can we do about that? Also, having adolescents write down short and long-term goals is very helpful, because we can then assess, is your drug use interfering with you reaching your goals? I also ask them, if you develop problem use, what would that be like? And finally, I know your friends, as an example, use marijuana regularly, but most kids your age don't. And actually, if they're really your friends, they won't care if you're using marijuana or whatever the drug of choice is. So I find those tips very useful. I've included some resources for you and also a short bibliography. And thank you for your time here, and I'll turn this over to Krista.
Thank you, Dr. Ammerman. That was very insightful and informative. Just as a reminder, we're going to hold questions until the end, but you can go ahead and type your questions into the Q&A box. And now I'm going to turn it over to Krista.
Great. Thank you, Shelley, and thank you so much, Dr. Ammerman. My name is Krista Ostertaylor, as Shelley said, and I'm from the American Association of Poison Control Centers. I've been working in poison control for just over 7 years now. In a couple of different parts of the poison control world, so it's interesting to bring these perspectives together. There we go. So a few years ago, when I did my first webinar for the Children's Safety Network, the topic was on liquid nicotine and e-cigarettes, and the word of the year just happened to be vape. And as I was preparing for this presentation, I discovered that the Oxford word of the year this year is toxic. So I thought that was kind of apropos. So about my organization, and I apologize to those of you for whom this will not be new information, but I think it's important to understand where the data that I'm going to present to you are coming from. AAPCC is a nonprofit. It's a member association. It was founded back in the 50s. And what we do is we represent the 55 United States Poison Control Centers, which employ about 1,700 people on our last kind of census activity. And the way we support and represent those poison control centers is through advocacy. We accredit the centers. We run the certification exam for the experts that are answering the phone lines. We engage in a lot of communication activities, public education. We promote the local services and many other things. We also collate and disseminate the National Poison Data System, and I'm going to be talking a little bit more about that in just a minute. And we engage in national educational partnerships and outreach initiatives. And just in case I forget to say it later, I want to make sure I emphasize to those of you who don't know that poison control centers, as part of their accreditation standards, they have to engage in public education activities. And so if you are ever interested in partnering with your regional poison control center, I'm sure they would be happy to hear from you about your ideas for public education activities. And finally, I'm located in Old Town, Alexandria, Virginia, just outside of Washington, D.C. So now about our members. Like I said, there are 55 centers across the country. They provide information and treatment advice year-round, every hour of every day through the National Poison Helpline. That number is 1-800-222-1222. Poison Help covers 100% of the United States population, including the territories, and help is provided in 150 different languages. Calls are free. They are private. They're answered by clinical experts. These are not volunteers that are answering the phone. These are actual clinicians who, and many of whom have undergone additional certification in toxicology. And finally, all these poison centers that are taking all these calls, about 9,000 a day, feed information about those calls, data from those calls, into the National Poison Data System, which is the only near real-time, and by near real-time I mean about every 8 minutes we get new data into NPDS, Poisoning Surveillance Database in the United States. And I'm going to be talking about the data that we are seeing on synthetic cannabinoids. So who uses poison control centers? Well, you've got the public, certainly physicians, nurses, and pharmacists, and then a wide variety of other people from different fields. So now I have a quick and easy poll question for you. Do you have the national number for poison control saved in your smartphone? And I guess I should have put a not applicable on here because I see on our attendee list that we have a lot of poison control people. So you guys, I'll give you the benefit of the doubt. Just say yes. Okay, looks like we've got a lot of honest folks saying no. That's great. That means I get to grab a whole bunch of new folks to get into your phones today. And we even have a couple of people on the poll that are saying, I don't have a smartphone. I can respect that. Sometimes I wish I didn't have one either. It doesn't strike me as all that smart all the time. All right. So, in case you're wondering how to get that number into your phone, here's an easy way to do it. If you text the word poison, P-O-I-S-O-N, to 797979, you're going to get a text back with a link to download a V-card. And a V-card is just a contact card, and it'll make Poison Control a contact in your phone, and you'll be prompted to save that. If everyone is doing it at once right now, sometimes it will take a few minutes for them to text you back. The system, we've discovered, can get overloaded if more than a handful of people are trying to do it at the exact same time. But it will the system will catch up with you. And then you'll have it in your phone. Okay, so about the National Poison Data System, again, this is where all the data from the calls that poison control centers around the country are receiving, it's the system that those data points are fed into. And like I said before, we get new data every 8 minutes. And when poison specialists who are answering the calls are coding information about each case, one of the obviously most important things for them to code are the products or substances that are being identified in the cases. And so there is a substance database that they use for this. It's got over 435,000 different specific products and substances. And when they can't find a specific product or substance, they will use generic substance codes instead. So they have to put some sort of substance in there. We do have geocoded data with caller location as granular as 5-digit zip code. So we know where these calls are coming from, and we know which poison center is receiving them. And data collection began back in the early 80s. So we have over 30 years of data and more than 60 million case records. So we have a pretty good picture of trends over time in terms of substance exposures. This is just a quick overview of the kinds of things that the poison specialists are grabbing in terms of data points from callers when they call. You obviously have your patient and exposure details. Those are, things you would expect. The age, gender, weight. Whenever we can get the weight, that's usually very important. The call type, whether it's an exposure or someone is just calling for information about a substance. Caller location, and on reason, route, duration, scenarios, the medical outcome. But we're also grabbing things like the clinical effects, the relationship of each substance reported to the clinical effects that are observed in the case. We're also grabbing things, obviously, about the substance, the certainty of the amount, the formulation, the quantity. We assign a sequence number if it's multiple substances. And then finally, therapies, whether the therapy was recommended by poison control and whether a healthcare facility actually did the therapy that was recommended. I'm going to give you a quick overview of the 2017 NPDES data set, and I want to do this because we're going to revisit some of these data elements when we look at synthetic cannabinoids. So I'll go kind of fast here. If you look at the age distribution of cases that poison control sees, this is just from 2017, but it's about spot on over the past several years. About 59% of our call volume is really about what I would consider youth, teenagers and under. If you look at the reason for exposure for people calling poison control, 77% in 2017 were unintentional. Not necessarily to be confused with accidental, but for purposes of this, you can think of it that way. The route of exposure, about 79% of the cases that were managed by poison control in 2017 were ingestion, somebody swallowing something. But I always like to point out that you can call poison control for any kind of exposure, including somebody getting something on the skin, inhalation, breathing it in through the nose, through the eyes, through the ears, a bite or a sting. You can call poison control about getting something in your eyes, and so on. Most of our cases are of one substance. I know this is a very busy slide. People like it a lot, and I'm sure you can download this in my slides later, but I wanted to point out that if you're looking at the top 10 substances, stimulants and street drugs hits our top 10 groupings for children, teens, and adults. So novel psychoactive substances, that's what we're really talking about when we're talking about synthetic cannabinoids. Another phrase you could use to describe these are designer drugs. And what these are they're unregulated substances that have no legitimate medical use. And they're made to copy the effects of controlled substances. And they're introduced and reintroduced into the market in quick succession to dodge or hinder law enforcement efforts to address the manufacture and sale. This is a great infographic that I found on the British Medical Journal's website, and I'm using with permission. And it shows the 4 different types. And we're really looking at the cannabinoid novel psychoactive substances. And I put the link in there so you could go in and take a look at this infographic. But I think it was the best visual depiction I've seen of the 4 main types of NPS. Street names, there's a lot of different names for synthetic cannabinoids. And the site that I found, Spice Addiction Support, they're attempting to build a directory of names that are used for synthetic cannabinoids, and they have over 700 names in their directory. Most commonly referred to, I would say K2 and Spice are the 2 that I hear the most. Scooby snacks also, but there are many, many names for this stuff. And what I want to point out about how people are describing this is poison control folks don't like to refer to it as synthetic marijuana because there's nothing really marijuana about this. There's no marijuana used in the making of synthetic cannabinoids. We prefer to use the word cannabinoid to refer to the receptor that it's targeting. And one thing I wanted to point out, and this is a great description that came from drugfreeworld.org, is that these are synthetic chemicals. Again, this is not marijuana. And the chemical is actually sprayed onto these herbs and spices or whatever that base layer is. And the fact that it's sprayed is really important because that affects the potency. We don't know how much of whatever is being sprayed on there is being sprayed. And the other thing is we don't know what the chemical composition of this stuff is most of the time. And that's a really big problem for poison control because it makes a poison specialist's job, which is to provide tailored, evidence-based treatment advice, really difficult when they don't know what substances they're treating for and in what dose. And I've heard spies tell me that it kind of forces them to work backwards when they're dealing with novel psychoactive substances, especially if the patient that they're being consulted on is unconscious and can't even tell you what it was they took or what they think they took. But you have to decide on what the substance was most likely based on the symptoms that you're seeing and going from there. So it becomes a very different kind of case to manage. I want to run through these outbreaks really quick. There's 2 that I want to talk about. One was Illinois, but it ended up being several different states, and then one was Utah. So in March, the Illinois Poison Center notified the Department of Health that it was seeing these patients, or it was getting calls about these patients that had unexplained bleeding, and they had reported synthetic cannabinoid use. And so when the Illinois Poison Center initiated that investigation, they figured out that this was a real problem. And as of almost the end of April, they had 155 cases. 4 had already died from major bleeding events. And over half, all 81 that were analyzed clinical specimens from patients with a confirmed or probable case were positive for brodifacoum, which is a superwarfarin that is used in rodenticides. Now, I have an update on this. Well, I'll finish telling you about it, and I do have an update. And although the cases were clustered in 2 geographic areas of Illinois, at the time, no single product source was able to be identified. And according to the National Drug Early Warning System, the reason they think brodifacoum was added was that it is thought to enhance or extend euphoric effects of the synthetic cannabinoid. Now, my update is that since that index case, which was in March 8th, at least 320 more people have presented to healthcare facilities with serious bleeding and a strikingly abnormal coagulation profile. And the largest number of patient presentations were in Illinois, followed by Wisconsin, Maryland, Missouri, Florida, North Carolina, Indiana, Pennsylvania, Kentucky, Virginia, and West Virginia. And they confirmed via lab tests the presence of brodifacoum in about 150 patients, and there have been at least 8 fatalities. So, you know, this really became a big deal. Now, the Utah case was a little bit different because people were using what they thought was cannabidiol, which is a non-psychoactive compound derived from the marijuana plant. So they didn't realize they were being exposed to synthetic cannabinoids. 5 patients experienced some pretty severe adverse reactions. And by the end of January of this year, there were 52 cases, and 9 of the product samples were found to contain a certain synthetic cannabinoid, but no cannabidiol. Again, the problem with these novel psychoactive substances, we don't know what's in them. It's really hard to treat these patients. So what? Well, at least one study is suggesting that synthetic cannabinoids are 30 times more likely to harm users than regular marijuana. And I wanted to see, do poison control data agree with that? So the 3 questions that I wanted to answer with poison control data were about which age groups are we seeing the most calls, where are the calls coming from, and my idea there was that if the calls were coming from healthcare facilities and not from residences, then they're probably going to be more clinically significant. And finally, what kinds of medical outcomes are we seeing and how do they compare to traditional cannabinoids? So the first thing I did was look at the profile of ages. And at first it was sort of thought among poison control anecdotally that this wasn't that big a deal in the teen population. But then once you adjust for call volume, you see that it is actually, or at least in 2015, it was a very big deal in the teen population. So what this graph is showing you is that for every 100,000 cases, exposure cases for poison control, in 2015, 1,104 of those had to do with synthetic cannabinoids, whereas for the entire population of exposure calls, it was only 358. So and this was over the course of 5 years, 2013 through 2017, with some dramatic decreases in 2016 and 2017. And I don't have any concrete evidence as to why we saw the spike and then the drop. If you look at the average across the whole 5 years, 656 out of every 100,000 cases were teens. So we saw, on average, the past 5 years, about 3,700 cases of exposure to synthetic cannabinoid. If you look at the collar site comparison, if you look at all of our human exposures by collar site, you can see that about 22% per year on average are coming from a healthcare facility, with a lot of them coming from a residence, 70%. But if you look at the calls that we're getting about synthetic cannabinoid exposures, 83% of those calls are coming from healthcare facilities. And that's a really big deal. That's saying that these patients are already there and the healthcare facility has reason to call poison control about the cases. And that's very telling to me. If we look at medical outcomes, I put these slides in here just so you know what I mean by moderate to major medical outcomes. But with your moderate to major medical outcomes, you're likely going to need assistance or treatment. If you look at traditional cannabinoids for the past 5 years of data, about 49% of those cases resulted in at least a moderate outcome, if not a major. Whereas if you look at synthetic cannabinoid exposures that poison control manage, 63% have at least a moderate outcome, if not major. So the problem here, the one caveat I will say is that people who are happily hallucinating or happily high are not going to healthcare facilities, and they're not calling poison control. So you've got a little bit of selection bias here, but it's still a significant difference, in my view, to have 63% versus 49% having at least a moderate effect. And that is it for me, but I put a whole bunch of sources of information that I used in this presentation and also that I found interesting. Feel free to contact me if you have any questions that we're not able to answer in the next few minutes. And if you're interested in NPDES data for this substance or any other substance, feel free to email data requests at aapcc.org.
Thank you, Krista, and thank you both to you and Dr. Emmerman. We have several questions already. We've got about 14 minutes or so for questions. So I'm going to start off with some of them. And Dr. Emmerman, this is probably for you. It says, sometimes we only have one shot with teens as they may not return to the clinic anytime soon. What's your advice for using Espert as a potentially one-time intervention?
Well, I think that it's definitely better than a good way to address substance use issues. However, and you bring up a valid point that it can be difficult to get adolescents to return to clinic, especially for something they may not want to, or they're not motivated to come back for, such as their substance use. But often we will find other kinds of other issues that they have where they need to come back, whether it's some other common medical adolescent issue or other mental health issue that they might want help with. And then we can continue to address the substance use problem. Clearly, if an adolescent is using, whether it's infrequently or on the other hand, problem use, a single visit is not going to be adequate to really help. So it's really important to try to engage the adolescent as much as possible to return, because it's going to take some time to really be able to help the adolescent cut down or cut back their substance use.
Okay, thank you. Next question for either one of you. Are the ingredients used in the manufacturing process for synthetic cannabinoids readily available, and what are the major ingredients? So it's two questions there.
I'll start. I would say yes, that the chemists have access to these chemicals that are used. As Krista mentioned, they are sprayed on, and it's very easy to obtain these chemicals if you're in the manufacturing business of synthetic cannabinoids. Krista?
That is just about what I was going to say, and I was also going to say that it's my understanding that a lot of these things are coming from overseas as well, and are being manufactured overseas.
A lot of this is being utilized, I would also say, through the dark web.
Yeah, for sure.
Krista, I believe this next question is for you. In terms of contacting poison control, what do you recommend for remote locations with limited access to cellular connections?
There are ways to use poison control online if you Google poison control, but I'm wondering if you have limited ability to call, if you might also have limited ability to use the internet, in which case I don't think we'd be able to help very much. Calling is definitely the better option if that's possible for you, and if you can call, we can help you in any language and from anywhere in the country.
Okay, thank you. Next question. Can this drug be used in vape, and if so, can it be smelled? Either one of you.
If it is sprayed onto a plant material, which is technically what is vape, which is actually the bud or the leaf then the answer would be yes. And as with all vaping, it minimizes or deletes the actual smell.
Okay. Could you explain what CBD is and what connection it has, if any, with marijuana?
CBD stands for cannabidiol, and the marijuana or cannabis plant has over 200, if not 300 or 400 different cannabinoids. The one that we know most about probably is THC, which is, I noted, is the one that gets you high. It's the psychoactive cannabinoid. CBD is a non-psychoactive cannabinoid, as Krista mentioned, and it will have some medical therapeutics in terms of, for example, CBD. A CBD product was just approved by the FDA this past June called Epidiolex, which is now used in pediatrics for intractable seizures in children. So there may be some medical benefit of CBD, but there's been very limited research on cannabinoids, particularly in the United States, because cannabis is a Schedule I drug, which highly limits any research on cannabis.
Okay.
But you got any dispensary, you'll be able to get lots of CBD products as well as THC products.
What are the impacts of synthetic cannabinoids on pregnant women and infants?
That's a question for you, Doctor.
Yeah, as far as we know, they're problematic. We don't have a lot of data on this, and it's mainly more anecdotal. But we do know that use of cannabis during pregnancy can cause both neonatal potential problems and even problems in childhood and even beyond from the fetus that was exposed to marijuana. And there's no reason to think that use of synthetic cannabinoids, which may be stronger and more toxic than cannabis cannabinoids, would not cause even more problems than that. So definitely our advice is for pregnant women to not use either marijuana or definitely synthetic cannabinoids during pregnancy.
Okay, and the next is actually two questions. Has the legalization of marijuana in many states helped to elevate the use of the synthetic cannabinoids, and are we seeing this trending in any parts of the country?
That is a really good question. That would be something I would love to dig into. I don't know the answer. I thought your question was going to be, have we seen increased poison exposures to or calls to poison control about marijuana in legalized states, and the answer is yes to that one. But in terms of synthetic cannabinoids, I don't know. I have not compared those numbers yet.
Yeah, it's a great question. Don't know.
Okay, sounds like a research project. Next question is, does synthetic marijuana look the same as regular marijuana?
Some of it looks similar in terms of just the dried, crunched up, but because they're spraying this stuff on a substrate that looks sort of like marijuana in some cases, but it varies a little bit.
Because it can also be, like, for example, there is bath salts, as an example, which don't look like marijuana, but, look like bath salts, can be one method of producing synthetic cannabinoids. So there is variation.
Yeah.
Do either of you provide or know where our listeners can get access to resources for parent and youth educational materials on synthetic cannabinoids?
I would recommend The American Academy of Pediatrics has a lot of information on substance use in general and marijuana more specifically, but also some information on synthetic cannabinoids. If you go to aap.org and you just type in what you're interested in, through your search results, there should be something that comes up. And if more specifically for marijuana, not synthetic cannabinoids, but for marijuana, if you go to aap.org/marijuana, there are a lot of resources, and these are all open to the public at no charge and downloadable and so on. So I would recommend that.
Okay, it looks like we've got only about 3 more minutes left, and so I'm going to have to pick and choose the questions. Is the sale of synthetic cannabinoids being controlled through the Internet at all?
Yes. Oh, is it being controlled as in regulated, or controlled as in is that where it's happening?
The question is it being controlled through the Internet?
Well, I mean, there's not, it is easy for anyone to get synthetic cannabinoids through the Internet if they want.
Yeah.
There's no control in terms of, oh, you can't sell it, you know, and so on. Again, some of it's done on the dark web, but you can also just get it on the regular web as well at times.
Okay, this question is regarding THC oil. Is it possible to overdose on that?
Yes. As a matter of fact, what Krista was saying, there's been overdose of in states where it's been legal, and a lot of that is due to edibles and drinkables.
Yeah.
Where THC oil tends to be more highly concentrated, but it can be used in different forms. One is dabs or wax, which are high potency THC, sometimes 80 to 90%, and even smoking that or vaping that can lead to a lot of adverse consequences. And then edibles, what I see with a lot of adolescents, they'll take an edible and nothing happens in 10 or 15 minutes, and they'll do another one, nothing happens in 10 or 15 minutes, and they'll do another one, not realizing it can take an hour or two for the onset of effects for edibles or drinkables versus smokables or vaping, which is minutes.
Okay. And do either of you know where we are concerning testing for synthetic cannabinoids? How much longer until we can test for this drug?
I don't know the answer to that.
It's a problem because if you come up with a specific test for a specific chemical, and that's how a lot of these manufacturers get around this, is they'll just change, you know, a carbon or one other group, so it may not show up just because of how it's changed. So I think we're still a ways away from being able to really test for these in a comprehensive manner and have accurate information.
Right, in a reliable way.
And probably one final question, Krista, and this is for you. Does Poison Control use telehealth as a contact source? Are you using telehealth?
Some centers are, yes.
Okay. Well, I want to, again, thank our two speakers for two very informative and excellent presentations. Thank you to everyone who was on the slide or on the call today. Just as a reminder, please fill out the evaluation, and this webinar will be archived, and you will have access to it at a future time. Thank you very much, everyone.
Thank you all.
Thank you for having me.